Okay. Okay, so I wanted to talk about X-ray or clinical interpretation of X-rays. I'm going to show mostly chest X-rays and some abdominal X-rays and see how you go. And I might even show a CT scan that might help you with something. But let's just go through some of the common abnormalities on X-rays. I know you're all used to looking at what a normal X-ray looks like, but let's look at some abnormal X-rays and let's see if you can tell me what's going on. Don't worry about this. This is just the nasal prongs, this curly thing, this metal, seemingly like metal thing. But who can tell me what's going on in this X-ray?
It's a homogeneous opacity on the right, with the mediastinum being pushed to the.
That's right. So good. A homogeneous opacity on the right side, and there's mediastinal shift to the left. So Benji, what when you see something like this, what goes through your mind? Like, what are you thinking about?
Thinking more like more fluid or more solid that could be taking up space that's causing the shift of the midline.
Yeah, very good. You've jumped a step already, which is good. You thought about it being fluid or being a mass, some solid structure. Of course, if you see a homogeneous opacity, then there's four things conceptually it could be, isn't it? It could be consolidation, effusion, collapse, or a mass. And but you've jumped a step and said that, well, because there's mediastinal shift to the opposite side, then it's more likely to be fluid or a mass. And you're quite right, because if you've got consolidation or collapse, you're more likely to have the mediastinum in the midline position or shifted to the side of the pathology. So I hope everyone can sort of see that. Now, Benji, in terms of thinking about, could this be, could it be a fluid or a mass? Can you make any suggestions on top of that?
At this point, I don't think I'll be able to make it on an AP view. Probably if we did a lateral.
Yeah, I agree with that. I think that it could be either. Sometimes you can see the appearance of a whiteout of the chest and say it looks like it could be a mass because of the shape of it, but this is the entire thorax whited out, and it's much more likely that even if there was a mass there, then certainly there's an effusion there, and the effusion's probably quite large. So sometimes when you've got a solid structure or a mass, you can have both a solid structure and an effusion, can't you? If you've got a tumor, say a teratoma or some other tumor of the chest, then you can have an effusion related to that. So it doesn't have to be either one or the other. It could be both. But of course, statistically, it's most likely to be an effusion, isn't it? Because effusions are much more common than chest masses. Anything that tells you that it's not consolidation, or it's not only consolidation. If it was consolidation, what would you see?
If it was consolidation, I think the expansion wouldn't be as much.
Yes, yes.
So there'd be a bit more crowding. As probably you would also see a bit more changes on the other side. Similar, like a lot of homogeneous opacities on the opposite side, you'd at least see some changes, but I'm not too sure.
Yeah, no, that's right. The only thing is on the side of the pathology where there's an opacity, you should be able to see some air bronchograms, shouldn't you, in consolidation? And so you need to look for air bronchograms. If they're there, then it might be consolidation. If they're not there, then it's more likely to be an effusion or a mass, but most likely an effusion. But this was a small child who had 1 liter, 1,000 mils of effusion, purulent effusion drained from the chest just this week. And so what it tells you is that there's a large amount of fluid in this chest when you've got a complete whiteout with that degree of mediastinal shift. Okay, that's good. Hope everyone sort of caught on to that. What about this? Anyone else? So similar opacification of the right side of the chest, but some subtle differences. What do you think is going on there? There's something else you see in this picture that you didn't see in the last one, and that is that small area of aeration, isn't it? In the lower lobe, there's a small area of aeration, which means there's some air there because it's black in the lower lobe. And so you could see this appearance if you had a chest mass. On the other hand, it could be a large effusion that's just superior, and there's a small amount of aeration inferiorly. You can't tell from this whether it's an effusion or a mass. It doesn't look like consolidation because you can't see air bronchograms throughout it. And it doesn't really look like collapse because the mediastinum is not shifted towards the side of the pathology. All right, so I just wanted you to see that. If I saw this, I'd be a bit suspicious that there could be a mass there because you've got some aeration below it. But on the other hand, it could be just be a large collection of fluid, which in fact it ended up being. But if you were to try to distinguish between an effusion and a mass, what would you do? What would be the test that you would request or do yourself or order?
Well, diagnostic test.
Yeah, well, that's true. Sometimes you can do a diagnostic tap and then do another X-ray and see what you're left with. Because if for example, it's a mass, often there's fluid, and when you drain the fluid, what you're left with is the mass. And you can see it more clearly on the follow-up X-ray. And the other way you could do it is do an ultrasound to look at whether the lung structure seems normal, whether there's a mass associated with it, or even do a CT scan. You could do. But I think your suggestion, Benji, is quite practical, and that is to drain the effusion that's there, and then do another X-ray to see what you're left with, see what is left afterwards. Sometimes it can be a bit dangerous to drain if you really think there's a mass there. Obviously, you don't want to put a needle inside a mass, which might be vascular. But sometimes it's what you could do is just do an ultrasound scan and just see that there's a fair amount of fluid there, and then that can be drained, and then see what's left after that. I'll get on to ultrasound of the chest in a moment. I want to show you a particular ultrasound of a chest so that you can get a good idea of what. So this was in fact this child, right? So this child, it wasn't very clear whether this was fluid or whether it was a mass. And so an ultrasound of the chest is this child's ultrasound. And I want to go through it. What's this structure here?
Liver.
The liver, good, very good, Ernestine, that's very good. That's the liver. And so this structure here above it, the band above it, what's that? Ernestine, you said that you said quite rightly that this is the liver, and above the liver is what?
The pleura, is it?
The what, sorry, say that again.
The pleura.
Yes, even before the pleura. What comes before the pleura? Just above the liver.
Diaphragm.
Yeah, good. The diaphragm. So what you look, that's right, Ernestine. What you're looking at here is the diaphragm. Okay, and then above the diaphragm should be the lung. All right. Now, those of you who are used to looking at effusions on ultrasound might notice something here, and that is that this part here is the lung, right? This part here, but this all around is an effusion. So this area here, this is lung, this small wedge-shaped opacity there, and this is fluid all around it. And what can you see about the fluid? What do you see about it?
There's fibrin strands in between.
Yeah, very good, Wilma. There's lots of fibrin strands, isn't it? It's not just black looking like clear fluid. So it looks like quite a very complex effusion, or you might call it an empyema, right? And if there's heterogeneity of the echogenicity, right? So there's differences in echogenicity, some where there's marked echoes and some where there's not, then it's more likely that it's a complex effusion with fibrin strands, and so therefore it's like an empyema. And you can see what's happened to the lung here.
It's restricted.
That's right. The lung is collapsed. The lung is collapsed because of the effusion surrounding it. So that was this chest X-ray, and that was this ultrasound. So simply by doing an ultrasound where you identify the liver, you identify the diaphragm, you identify the lung, and then you identify the fluid surrounding it, you can get a very good idea of whether or not it's a simple effusion. If it was just all black, then it's a simple effusion. You can stick a needle in it and drain it, and you'll probably, even if you stuck a needle in here, you'd probably drain all of this fluid coming around here and the fluid up there. But if it's a very complex effusion with lots of fibrin strands, and it's what we call organized or chronic or complex empyema, then sometimes putting a needle in here or a drain in here won't drain this other pockets of fluid, because it's simply not close to, it's walled off from where you put the drain in. So I think it's good to get some experience with doing ultrasounds of the chest to see what you can see, identifying the lung, identifying the fluid if it's there, identifying whether it's simple or complex, and identifying the normal structures like the liver and the diaphragm. Okay. All right. What about this X-ray? This was a young infant who presented with respiratory distress. What can you see on that X-ray?
Maybe like a right lower lobar collapse.
Yes, that's right, Benji. It's right lower lobe collapse, and when you're looking at an X-ray, you should be able to identify the left heart border, the left hemidiaphragm, the right heart border, and the right heart border and the right hemidiaphragm. But in fact, you can see the stomach bubble there, and you can see the liver, but you can't see the right hemidiaphragm very well. And what you can see is this wedge-shaped opacity, and it looks like it's got perhaps some air bronchograms in it. So this is right lower lobe collapse or consolidation. And there's a couple of things that are a little bit unusual about this, in that normally if you see collapse, then you'd expect that the mediastinum would be shifted to the ipsilateral side, so the side of the pathology, but it looks, if anything, like the mediastinum is a bit shifted to the opposite side. But why is that? Can you say why that is, just looking at the X-ray?
Looks like there's some pneumothorax on the right side, because the right lung feels like there's, it looks, yeah.
Yes, well, that's a good thought as to whether or not there's a pneumothorax in the right lung above the area of collapse. That's a good thought. But what's the other thing that you see though when you look at the X-ray? Do you think it's a well-centered film, or it might be a bit rotated?
It looks rotated.
Yeah, I think it's probably rotated quite a lot to the left, and what that does is give you the appearance of that the mediastinum is shifted, if anything, to the left, whereas probably if it was a better centered film, then the mediastinum would be a bit straighter, and there wouldn't be such an appearance of asymmetry of the chest. This probably isn't a pneumothorax, but sometimes when you've got an area of collapse, then you get an area of hyperinflation above it, because the right lower lobe is full of mucus or secretions, and that's caused collapse with an infection there. And so the right upper lobe is taking all the air, and there may even be an element of gas trapping in the right upper lobe, leading to this over distension of that right lung. I think it's a little complex, but I think you just should identify that this is a rotated film, so perhaps the clinical signs don't match as well as what they might, but this is clearly an area of a large area of right lower lobe collapse. Okay. All right. What about this X-ray? Can someone have a go at this one? What do you see? I mean, it's always worth just starting from the start and describing the X-ray, and then describing the normal things and then the abnormal things. So what do you see?
So widespread opacities, especially the highlight region.
Yes.
It's got
There's patchy opacities around the hilar region on both sides, and some in the looks like perhaps in the left upper lobe and the left upper lobe and even the right upper lobe. There's patchy opacities. They're not so widespread, are they? Because there's some areas where there's aeration of the lung, so it's not like it's not homogeneous. There's these areas where there's sort of streaky white lines there. They're probably areas of atelectasis or collapse. But there's patchy opacities here. Is there anything else that you see that just looks a bit abnormal?
cavity on the
Say that again.
looks like a cavity on the right.
Very good, very good. In this area here, this area looks like a cavity, doesn't it? Because you've got an area of aeration surrounded by an area of consolidation. That's right. Well done. That looks like a cavity there. What sort of cavities could there be? Well, I guess conceptually you can have an abscess, or you could have a tuberculoma or a TB abscess cavity. It could be a bacterial abscess cavity, or sometimes you can have a fungal infection that leads to an abscess cavity. I don't know whether you can see, but if you follow the trachea down, you can see the left main bronchus, and then it looks like it's there's a lot of patchy opacity around the left lower lobe bronchus, and it almost seems to open out. So there's a bit of dilatation of that bronchi. What might that be? When you see the bronchi dilating up like this, so you can't always see it, but sometimes you get, and it's not diagnostic, it's just suggestive. So I would say that looking at the bronchi coming down here, it's suggestive of what? You can see some almost like cystic-like areas distal to the bronchi. What might you think that is?
Emphysema.
Yeah, it could. That's right. It could be a little bit of lobar emphysema, but it could be around what you've got the bronchi that seems to narrow down and then dilate up a bit. What would you think that was? Well, the bronchial tree should always starts large at the trachea and then it becomes narrower and narrower, just like a normal tree does. But if the bronchi narrow down and then enlarge, then we call that something. What's that? It's suggestive of bronchiectasis, isn't it? And so if you put this together, you've got a suggestion of bronchiectasis of the left lower lobe, and you've got a cavity in the right lung. So, and you've got patchy opacities throughout the rest of the lung. And so if you put this together, this could be, for example, a child who's got chronic bronchiectasis who's developed an abscess, right? Or it could be a child who's got TB related bronchiectasis who's got an abscess. It just looking at the X-ray doesn't tell you which one it is, but you can look at the X-ray and you can put together a sort of a story, if you like. A child who's got chronic lung disease who has some signs on the X-ray that are suggestive of bronchiectasis and now has an abscess cavity. Okay. All right. What about this X-ray? This is along similar lines, although it's a little different. What do you see?
It's like very high reticulonodular changes with
A few, yes, there are a few there. Yeah. You shouldn't overcall the perihilar changes. Sometimes that a small amount of perihilar changes can be within the normal limits. And I would have said, Benji, that if I only saw if the left lung looked like the right lung, I'd say, well, that could be normal, because you can see the right heart border, you can see the hemidiaphragm, you can normally see some bronchovascular changes in the right hilar region, and they look a bit. Sometimes we overstate the right hilar changes, because you think about it, if you took away the left side of the heart, then you'd probably see similar changes of bronchovascular markings on the left side. But because the heart's there, it's a bit obscured. So sometimes this can be within the normal limits, just normal bronchovascular markings. So that's all. What else do you see?
the left side is like a clearing with like a homogeneous opacities around it. It's the left.
Yes, there's a dense homogeneous opacity, which is in the sort of mid-zone, isn't it? You can't say it's in the middle lobe because there's no left middle lobe, but it's in the mid-zone of the lung. It doesn't involve the lower lobe because you can see the left hemidiaphragm, and it does involve the lingula because it's a bit obscuring the left heart border. All right, so it's in the mid-zone of the left lung. You can see this homogeneous opacity. And what do you think that could be, Benji?
Lung abscess.
Yes, so the lung abscess is probably here, isn't it, where you've got the area of translucency within a homogeneous opacity. And so what might you think this was? So it's an area of consolidation with a lung abscess, isn't it? It looks a bit walled off at the top, right? And there's consolidation probably around. So this would be like left mid-zone consolidation with a lung abscess. And what could that be due to? What things are running through your mind when you see this? You should start thinking about, well, what next? What could it be due to? What bacteria or what bugs could be causing this?
Yes, staph infection.
Yeah, that's right. It could be a staph infection. Yeah. What's staph, Benji?
Staph aureus.
Yes, Staph aureus, most likely Staph aureus, because that produces like abscesses within the lungs. Anything else it could be? What else could cause a lung abscess?
I can't think of any.
It's okay. Even Streptococcus pneumonia can give you this appearance. So when you're thinking of like a lung abscess, Staph aureus is the most likely. Of course, Streptococcus pneumonia can do it, and sometimes Group A strep can do it, Group A streptococcus. It's surprising how often when you do ultrasounds on children who've got pneumococcal, streptococcal pneumonia, do you find micro abscesses in the lung? All right, and usually when you see an abscess that's this big, then it's more likely to be staph. But it could be pneumococcus or streptococcus pneumonia, or it could be Staph aureus, or also it could be some other unusual bug like a E. coli or some gram-negative, but much, much, much less likely. If you've got an immunocompetent host, like this child was immunocompetent, there was no immunosuppression about this child, then having a Staph aureus lung abscess is the most likely thing. Good. So I just want you to be able to identify a lung abscess when you see it, and then think to the next step of, well, what could it be? And you should always think this could be Staph aureus. And when you're thinking about Staph aureus, Benji, what else should you think about?
MRSA.
Yeah, good. Yeah. So most Staph aureus are susceptible to flucloxacillin, but when you see like this X-ray appearance, then you should think to yourself, well, it could be a lung abscess. If it's a lung abscess, it could be staph. If it's staph, it could be MRSA or it could be MSSA, so methicillin sensitive Staph aureus. If it's MSSA, then I know the flucloxacillin or the cloxacillin is going to work. But if it's not MSSA and it's MRSA, methicillin resistant Staph aureus, then the cloxacillin or flucloxacillin probably won't work. And you need to be thinking about using some other agent, such as what, Benji? What else? What else would you think about using if you thought it might be MRSA? Yeah, that's right. And how could you, like, if you had this patient, if this patient was your patient, and you, how would you try to work that out? Because if you treat them with flucloxacillin and they don't get better, then what are the possibilities? Why might this child not get better with flucloxacillin?
Is to make sure that we get high dose.
Okay, so you've got to get the dose right, and why else might such a child not get better? If you even if you get the dose right, why else?
It needs to be drained.
Yeah, good. Sometimes, no matter what antibiotics you put the child on, if you don't deal with the collection of pus, then the antibiotics won't work. Now, if that collection is in the pleura, in the pleural cavity, then you can drain it with a chest drain. But if it's in the lung itself, then of course that's much harder. And normally we don't drain lung abscesses, do we? But sometimes, usually if you've got a lung abscess, it will be associated with some pleural fluid. And so it's well worth doing an ultrasound to see if there's pleural fluid there, because then you can drain some of the pleural fluid at least and get a specimen for which you can find out the type of bacteria and the sensitivities. And if you found that it was an MSSA, then usually you just keep going. If the pleural collection is drained, but you've still got a lung abscess, then usually we don't drain intraparenchymal lung abscesses. It's just too hard to get to usually. So antibiotics over time will work, but you want to make sure that it's a susceptible Staph aureus, because if it was MRSA, then you've got two reasons why it isn't, the child's not getting better. One, it's a resistant bug, and two, that the abscess is still there. So that's all. You just have to maybe go through that process of thinking about it and early identification. Instead of just saying this is consolidation, say this is consolidation with an abscess. If it's an abscess, it could be staph. If it's staph, it could be MRSA or MSSA. And what will I do to try to find out whether it's MRSA or MSSA? Well, I'll do an ultrasound to see if there's a collection there. If there's a collection, I'll drain it and then try to get the bug, try to find the bacteria. I mean, other ways you could find the bacteria. What's another way? Could you find out what type of, whether it's MRSA or MSSA? What else could you do if there's no pleural fluid there?
Blood culture.
Yeah, you could do a blood culture. Good, Ernestine. Yeah, you could do a blood culture. The problem sometimes, the problem with blood cultures in pneumonia is that mostly bacteremia occurs only in about 20% of cases, or even less. Sometimes it's down to about 5%. I think if you've got a staph pneumonia, then even still bacteremia only occurs in about 20% of cases. So often the blood culture will be negative. What else could you do?
Sputum.
Yeah, sputum, that's right. And a sputum in a child doesn't always tell you, like, what bugs are in the sputum won't necessarily be in the lungs. But if you got that clinical picture, the X-ray appearance, and you found Staph aureus in the sputum, then you'd say that's quite likely to be the staph that's infecting the lungs. And from the sputum, you might be able to, your lab might be able to tell you whether or not it's MRSA or MSSA. So that's the value in taking a sputum, I think. Now, recently I had a child like this who was too young to cough up sputum. So I thought, well, maybe we'll look at the gastric aspirate and see what bugs are there, just because, not because I think the bugs in the gastric aspirate necessarily are in the lungs, but if you found Staph aureus in the gastric aspirate and you found out that it was MRSA or MSSA, then you can at least target your antibiotics appropriately. So I guess the point I wanted to make is if you see a lung abscess, then look for pleural fluid. If you can't find pleural fluid and the blood culture is negative, then there are other ways in which you can try to determine what the susceptibility is of the staph that the child is colonized with. And that could be through sputum or potentially even a gastric aspirate. I hope that makes sense. Yeah. Okay. Here's another X-ray. This was a small child about 6 months of age who presented with severe respiratory distress. Who can tell me what's going on here?
Tissue opacities widespread.
Yeah, this is widespread, isn't it? There's widespread patchy opacities through both lung fields. Is it symmetrical or asymmetrical? Most of the time so far we've been looking at asymmetrical chest X-rays, haven't we? One side is affected more than the other. But what about this one? It's symmetrical, isn't it? And is there any sparing? Like when you're describing, there's widespread patchy opacities throughout both lung fields in a symmetrical distribution. Is there any sparing? Yes, good. There's sparing at the bases because you can still see the right hemidiaphragm and you can still see the left hemidiaphragm. So there's basal sparing, but the rest of the lungs look densely opacified, don't they? And when we said before, when you see a dense whiteout, then you think of consolidation, a fusion, collapse, or a mass. Does it look like a fusion or does it look like something else? It looks like consolidation, doesn't it? That's right. It looks like dense consolidation, not like an effusion and not like a mass, because you can actually see the shadow of the heart, all right? And you can see the lung fields quite clearly, and there's aeration in between. Yeah. If you were to see an X-ray like this, what would you think about? Remember, whenever looking at that X-ray before, we started to think, well, this could be consolidation of the left lung, it could be an abscess cavity, therefore it could be Staph aureus, and etc. Well, when you looked at an X-ray like this, what would you think about? There's no one right answer to this. So you obviously can't get the diagnosis from an X-ray, like the bacteriological diagnosis from an X-ray, but you can look at an X-ray and say, well, this is more likely to be these pathogens than, say, if there wasn't those changes. So if you would look at this X-ray, what pathogens would you start thinking about?
Viral?
Sorry, say that again.
Viral infection?
A viral infection, yeah, it could be. Certainly when you've got influenza, then you can have a picture that looks a bit like this. It's usually a finer pattern, I must say, Mane. It's usually not so blotchy consolidation as this with the influenza. Now, sometimes it can be, and I've even seen RSV this year look sometimes, usually, of course, RSV looks like hyperinflation with translucent lung fields, but I've even seen RSV give this appearance this year. So yes, you're right, a viral infection. And the reason why that seems sensible is because there's symmetry to it, isn't it? It's not just one side, there's both sides. So it looks like a generalized problem. So yes, a viral infection, viral pneumonitis or viral pneumonia could be the diagnosis. What else? There's a couple of other things.
From
Yeah.
PCP.
Yeah, very good. PJP, pneumocystis jirovecii. That's right. And in fact, that's what this was. This is a child who had pneumocystis pneumonia, and it's a child who had chronic lymphopenia. The child didn't have HIV, but chronic lymphopenia, just like as if the child had HIV, and the child had pneumocystis. That's right. So, and the features that make it look more like pneumocystis, for example, in viral pneumonitis, are that there's a bit more dense consolidation. It's not lobar consolidation, but it's a bit denser than you expect with viral pneumonitis. And you can see the almost patchy sort of nodules throughout the lungs. So this was a child who had chronic lymphopenia, low levels of lymphocytes, so immunodeficiency, not due to HIV, but had pneumocystis jirovecii pneumonia. So you've thought of viral pneumonitis or pneumocystis pneumonia, and there's obviously one other condition that could give you an appearance that's quite like this. Come on, what else?
TB?
Yeah, good, TB. Yeah, I mean, often people suggest TB first, but I was trying to get you to think it more broadly, and I think you've done that. So yes, this could be extensive TB. It's not quite a miliary pattern, but it's a much more dense it's a slightly more dense pattern than a miliary pattern. But it could be extensive bronchopneumonic tuberculosis, or it could be viral pneumonitis, or it could be pneumocystis. It could be a variety of things, but the point is to think, once you see an X-ray, then start thinking about, well, what pathogens could this be? Okay, that's the way I want you to start thinking. Yeah. Okay. Now someone tell me about this X-ray.
It looks overexposed.
See the lung markings.
I'm sorry, say that again.
Can't visualize the lung markings clearly.
You can't, it's hard to visualize the lung markings clearly. Quite right. Yeah, it is hard, isn't it? Yeah. And why might that be? Yeah, so there could be a pneumothorax. Yeah, that's true. There could be a pneumothorax, but you can see some lung markings, can't you? You can see the bronchovascular markings here, and you can see some lung markings on the right side as well. So there looks like there's some lung markings. What else could it be besides a pneumothorax? Sorry?
Hyperinflation.
Yes, very good. Yeah, yeah. This child's got bilateral hyperinflation of the lungs, and actually you can draw the outline of the left lung, which is here, and you can draw the outline of the right lung. See this line that comes down here? This is the right lung all the way across here, and you can see there's a little bit of collapse of the right upper zone, but the right lung is very over-distended, and the left lung is very over-distended. You look at how the hemidiaphragms are very flat, and the lung fields look really black. And when you see lung fields that are looking black, very, very black, it's either because it's an overexposed film, or there's a pneumothorax, or there's over-distension of the lung. And there's one other reason why you can see very black lung fields. What is the other reason?
Air trapping.
Yeah, air trapping, which is over distension of the lungs. That's right. So gas trapping, or that there's a pneumothorax, or it's an overexposed film. But there's one other reason, which is not the case in this child, but one other reason I want you to think about when you see really black lung fields.
If there's reduced,
I'm sorry, say that again.
if there's reduced blood flow to the lungs.
Very good, yeah, and that's right. So if you've got such as in what condition will you get black lung fields and reduced blood flow to the lungs?
The congenital heart disease.
Pulmonary
Pulmonary, say again, pulmonary.
embolism.
Oh, okay. Yes, if you get a pulmonary embolism, yes, sort of. Yeah, usually that you don't see that much. What's the classic condition that gives you reduced blood flow to the lungs, though, in black lungs?
Asthma.
Okay, asthma. That's more because of overdistension, isn't it? Gas trapping. But what's the condition where you have reduced blood flow to the lungs? Yeah, totality of flow. Yeah. So
So
okay.
pulmonary.
Okay. So we've thought about when you see black lung fields like this, we've thought about gas trapping and overdistension. We've thought about an overexposed film, right? We've thought about reduced pulmonary blood flow, like with tetralogy of Fallot. Is there any other reason why you might have reduced blood flow to the lungs? A common reason, and sometimes we see X-rays in these children, but we don't notice the abnormality. But I'll tell you, if you see a child who's got severe dehydration, right, and they're hypovolemic, then often when you look at their chest X-ray, their heart will appear small and their lung fields will appear very black. And the reason for that is their heart is not filled with fluid. It's a bit empty. It's not completely empty, because otherwise the child wouldn't have a cardiac output, but it's more empty than what it should be if you see a child who's got severe hypovolemia. And so what I want you to think about, not this child that I've just given you the X-ray of, but when you see very black lung fields, then think, is it overdistended because of gas trapping, or is there reduced pulmonary blood flow because of like right ventricular outflow tract obstruction, like in tetralogy of Fallot, or is there severe dehydration or hypovolemia leading to black lung fields and a small heart, or is it just an exposed film leading to black lung fields? Right? And of those, which one do you think this X-ray is? Yeah, it's a hyperinflated lung fields. That's right. And in what conditions will you see hyperinflated lung fields like this?
Asthma.
Good. Yeah, asthma. And anything else?
Bronchiolitis.
Good. Yeah, with bronchiolitis. This was a child who had severe RSV, but viral bronchiolitis. And you can see how overdistended the lung fields are. You can also see there's a tube going into the trachea. So this baby's on a ventilator, and but had an X-ray that looked like this even before she was put on a ventilator. In fact, yeah. So this is another child who, tell me about this one. So here again, you've got asymmetry. There's not symmetry, is there, of this X-ray? You've got a right lung that looks reasonably normal, but the mediastinum is shifted right across. There's maybe a little bit of rotation to the right, but not that much to explain the right-sided shift. But you can outline the left lung, and you can see the left lung pushes all the way across to the right. In fact, the left lung is pushing the mediastinum across to the right, isn't it? So what could be going on here? Yes, this could be a tension pneumothorax. Yeah, that's right. Is there anything else it could be? Yeah, it could be a very, very large pneumatocyst. There's some element of gas trapping here, isn't there? And either the gas is trapped in the pleura, as in a pneumothorax, or it's trapped within the lung itself, and the lung is overdistended. Can you think of anything else that might give you an overdistended lung like this? Did someone say a foreign body? Yeah, that's what this is. This was a foreign body, and a foreign body that had gone just down the left main bronchus. Now, foreign bodies usually go down the right main bronchus, but in this occasion, the foreign body went down the left main bronchus and caused what was like a ball valve obstruction to the left lung. All right, and so when you see a black over-distended lung, right, then it could be over-distension because of an infection or asthma, just any form of airflow obstruction, or it could be black lungs because of inadequate pulmonary blood flow, or because there's hypovolemia, or it could be a black lung because there's a pneumothorax, or it could be a black lung because of over-distension because of like a partial obstruction to one of the bronchi where air can get in, but it can't get out, right? And it's not always easy to tell the difference between all of these things, but again, it's the history and the examination that gives you a clue as to which one of those it is. So all I'm trying to do is get you to look at an X-ray and then have in your mind a differential diagnosis, and then try to work it out based on the history and the other radiographic appearances of what the diagnosis is. So in this case, it was an inhaled coffee bean into the left main bronchus, leading to over-distension of the lung. Now, of course, it could be something else too, like a congenital cyst of the lung, or it could be some other thing, but that's the way it was. Yeah. Okay, this is going a bit different now, and this was a child I saw just this week who came in with noisy breathing with stridor. There's one thing I wanted you to observe on this X-ray, that we're not used to looking at lateral neck X-rays, but I just want you to see one thing, one aspect of it. What can you see?
Soft tissue swelling.
Very good, Wilma, very good, yeah. And where's the soft tissue swelling?
Just under the jaw, the mandible.
Yep. There's a large soft tissue. That's right. There's a large soft tissue swelling here. But the clinical sign I wanted you to look at is this. So you can see the vertebral bodies here, right? And so the vertebral body of 1, 2, 3 going down cervical vertebra 3. What you should see in the prevertebral soft tissues should be no more than one vertebral body, right? And so here, the prevertebral soft tissues should finish about here, going down here, and finish about there. But you can see it's at least 2 or 3 vertebral bodies wide, the prevertebral soft tissue. So not only is there soft tissue swelling under the mandible, but there's also a very large retropharyngeal soft tissue swelling. Right, and so I hope you can see that. It's a very stark example of a large retropharyngeal or prevertebral soft tissue swelling. All of this area is swollen soft tissue. So what could that be due to?
Retropharyngeal abscess.
Yeah, good. Yeah, this was a large retropharyngeal abscess in a child of about 9 months, and you can see it by that. It could be a number of other things, but primarily you'd be thinking a retropharyngeal abscess or a retropharyngeal cellulitis or something like that. But the main point I wanted you to identify is to be able to look at a lateral neck X-ray and see that what the prevertebral soft tissue dimensions are, and if it's more than one vertebral body across, then there must be abnormal swelling of the retropharyngeal tissues. Right? All right. This was a child of, again, 5 months who presented with mild to moderate respiratory distress and had an X-ray taken. What's going on here? 5-month-old child.
Probably has a diaphragmatic hernia.
Yeah, very good. There's a diaphragmatic hernia, and And what's surprising about that X-ray appearance in the clinical picture? The bit that's surprising in a way is that the baby's 5 months of age, isn't it? Usually we get used to diaphragmatic hernias occurring in newborn babies and diagnosing them in the newborn period. But what does it tell you if a child's got to the age of 5 months with a diaphragmatic hernia?
It's good information on the right side.
Yeah, very good. Yeah, that's right. The child must have enough lung to live. And some babies are born with diaphragmatic hernias that clearly they, when a child has a diaphragmatic hernia, it's not just like a defect in the diaphragm leading to the abdominal contents being in the chest. It's not just that. There's also an element of lung hypoplasia, all right? And with lung hypoplasia comes pulmonary hypertension, because you've got very small, all the structures of the lung, all the tissues of the lung are small, and that can lead to pulmonary hypertension and inadequate lungs. But if a child gets to 5 months of age and they've been relatively asymptomatic, then they must have enough lung to live, all right? It must be that they've not got severe lung hypoplasia. This child was failing to thrive, but was still not diagnosed until 5 months of age. So therefore must have enough lung to live. And the circumstances in which I've seen late presenting diaphragmatic hernias have mostly been in children who get some respiratory virus and someone does an X-ray and they see the diaphragmatic hernia there. It's almost an incidental finding, but it means that they must have enough lung to live. So the other thing you see here is that the nasogastric tube's gone down, but it's come back up again. It certainly hasn't gone into the stomach. Yeah. Now here's another picture. What do you think about this?
Might be a cyst.
Yeah, it could be a cyst. That's right. It could be a big lung cyst on the left, but when you look here, what does this look like? These things here.
Probably bowel outline.
Bowel outline, that's right. So this was a more, I've seen more of this type of late presenting diaphragmatic hernia than I have seen of this one. This is the only one I've seen where there's a lot of small bowel in the chest. Mostly the ones that I've seen 4 of these late presenting diaphragmatic hernias, one with small bowel in the chest, but other ones that have looked like this. So, and what do you think's in the chest here on this one?
Large bowel.
Not so, you wouldn't normally get the large bowel in the chest, because the large bowel is adhered down to the the retroperitoneum. You don't usually have much mobility about the large bowel. But what is close to the diaphragm that might move up into the chest?
The stomach.
Yeah, good. So this is the stomach in the chest. This is a child who was 2 years of age and presented again with an incidental finding of a respiratory during a respiratory infection, of having the stomach in the chest, and with a small amount of small bowel. Sometimes the spleen can be in the chest, sometimes the bowel, or sometimes the stomach. And the other way these children can present is if they get a respiratory infection, or if the stomach or the structures of the small bowel twist in the chest and lead to a torsion. And some children I've seen have a torsion of their stomach, and that causes obstruction. So therefore you get progressive further dilatation of the stomach. Now, what could you do to try to deal with this? You can see there's a lot of asymmetry. The mediastinum is pushed right across to the right side. The child's in severe respiratory distress. What could you do? Simple things you could do.
Put an NGT and suck out the air.
Yeah, that's right. Yeah. So here's the same child with a nasogastric tube being passed, and you can see the nasogastric tube is being passed down the esophagus and then up into the stomach, which is in the chest, and sucking it out can drain the fluid from the stomach and therefore deflate the stomach. And now you can see that this girl's got an adequate an adequate lung on the right side and is able to breathe okay. Now, I've seen some children that you're able to pass the nasogastric tube, and then some children that you're not able to pass the nasogastric tube. It just won't pass because there's a torsion or a twisting of the stomach, so it won't, the nasogastric tube won't go into the stomach. The only way you can try to deal with that is by putting a needle in through the wall here into the stomach and draining the fluid out like that. I wouldn't suggest you do that, but I've done that on one occasion, and that deflated the stomach, so it allowed the tamponading effect of the stomach on the heart and the other lung to be relieved. But put in a nasogastric tube, that's right. Yeah, that's a good thing. Yeah. Okay. So sometimes when you put in a nasogastric tube, this could happen. What's happened here?
It's not gone down to the stomach in the abdomen. It's gone into probably into the left lung.
Yes, it's gone into the left main bronchus, hasn't it? It's gone to the left lung. A very dangerous thing to do. And how can you, what can be a clue that might happen? What do you think the clues are?
Probably have bubbling.
Yeah, you could get bubbling. What's a clue even before you get bubbling? Sorry? Yeah, they'll cough and they'll be very, very uncomfortable. And so I think mostly when you, unless the child's unconscious, when sometimes you can do this inadvertently, mostly if you've got a child who's semi-conscious or fully conscious, they'll cough incessantly if you put a nasogastric tube down into the lung. And so that should be the clue. You should never, if you can't aspirate gastric juice and the child's still coughing or gagging, then just take it out. All right. Of course, the nasogastric tube should be in this position, maybe even a little bit further down. Okay. Now, lastly, I think this is the last case, but I wanted to show you a CT scan, and I wanted to show you this case because we see a lot of gastrointestinal sepsis, but we don't like diarrhea or major problems with the gastrointestinal tract, but we don't always, not always able to see changes on the x-ray. But I just wanted to show you this. This is a CT scan of a child who had abdominal distension, vomiting bilious and bloody secretions. And this is, I just wanted to show you the CT scan of her abdomen. This is looking from front to back. All right. And so I'll show you a couple of times, looking from front to back. And then it's looking from back to front. I've just changed it so it's going back to front as well. Okay. Now I don't expect you to be like experts in the way to read CT scans of the abdomen. That's a hard thing to do. But can anyone see any abnormalities? I've ended on a still picture of where the major abnormalities are, and I just want you to try to identify what the abnormalities are. Yeah, where's the air? That's right, Benji. Where's the air? Throughout the bowel. That's right. And of course, you normally have air within the bowel. But what can you see here? All these small dots, these black dots. What do they look like? It looks like air. What would you call that? What would you call these black dots then?
Pneumoperitoneum or something.
Yes, a pneumoperitoneum would usually have air within the peritoneal cavity, and there is some air in the peritoneal cavity down here. That's right. What's the name for the air in the wall of the bowel?
Intramural.
Yeah, very good. Intramural gas, or sometimes called pneumatosis. Pneumatosis coli is the full name for it. So this is severe pneumatosis where you can see almost all the bowel wall has air in it. And there is also pneumoperitoneum. And there's more than that. where else can you see air?
In this,
Yeah, air's gone up to the liver, hasn't it? There's extensive air in the liver. I'll just show you the whole thing again, going from front, right? From front to back. And so there you can see the kidneys and the back part of the spleen, the kidneys, the liver coming into view now. And most of it, the first part looks okay, but then you start to see some air there in the very anterior parts of the liver. And there you see extensive gas within the liver. So if you were to see this again, looking at an X-ray like this, what would you then be thinking about in a child like this? What would you think about?
Yeah.
Did someone say staph? Not typically, because staph will usually give you abscess formation, but not so much pneumatosis or air. The other thing I should say is that looks like there's a lot of fluid here. This doesn't look like bowel. This looks like fluid, isn't it? So there's ascites, there's pneumatosis, there's pneumoperitoneum, and there's gas in the liver. What else could you think about? I'm sorry? Did someone say pig bell? Yeah, that's right. Yeah, this is the same as pig bell. All right, this was a child who had, what's pig bell due to? Clostridium perfringens, isn't it? This was a child who had Clostridium perfringens sepsis, and found on blood cultures, but also found on the fluid from the peritoneal cavity. And this is what you get when you've got pig bell, when a very bad case of pig bell. Sometimes it's only mild and there's not too much pneumatosis, but this was Clostridium perfringens sepsis in a severe way, and you can get extensive pneumatosis, and you can get gas within the liver. So yeah, I guess I wanted to show you some x-rays where when you see the x-ray, you can start thinking about, well, what pathogens or what could be the underlying cause of this? And if you saw pneumatosis on an x-ray, then if it was a newborn baby, you'd think about necrotizing enterocolitis, like it was a premature baby. And if it was an older child, like this child was, then you'd think about Clostridium perfringens sepsis, which, remember, Clostridium are gas-producing organisms. They produce gas. So most likely, when you saw an X-ray like this, you'd say this is probably a Clostridium or an anaerobic infection that's gas-producing. Okay. All right. Okay. Well, that's all I wanted to show you today. We've looked at X-rays of the lung. Maybe I'll just share it one more time. And yeah. Okay, so we've looked at empyema, and we've said that it's good to do an ultrasound of an empyema to see whether it's simple or complex, right? And sometimes it's good to drain it and then do another X-ray or another ultrasound to make sure there's no mass there. And if you see a white out of the chest, then it can only be one of four things. It could be fluid or consolidation, where you should see air bronchograms, or it could be collapse, where you've got the mediastinum typically shifted towards the side of the affected lung, or it could be a mass where the mediastinum shifted away. Right? We talked about lung abscesses and how you should then think of that could be staph, and in that case what type of staph it could be. We've thought about a diffuse interstitial process, and in this case it was pneumocystis, but it could be miliary TB, or it could be viral pneumonitis or something else. We've thought about the causes of hyperinflation, and we thought about like bronchiolitis or asthma, but we also thought about the other reasons why you can get the appearance of hyperinflation, such as if you've got obstruction to the pulmonary outflow tract, and you've got black lungs because of oligemic lung fields, or if you've got over expansion, over exposure of the X-ray, or you've got a pneumothorax, or you've got just a child's got severe hypovolemia, like gastroenteritis and severe dehydration. That can give you black lung fields. But it's where you've got overinflation, hyperinflation, then think of bronchiolitis or asthma or a foreign body or something like that. Yeah. We thought about retropharyngeal airspace enlargement in the setting of a retropharyngeal abscess. So remember, the other setting in which you can sometimes see that is if you've got trauma to the cervical spine, then you get bleeding, and that can enlarge that prevertebral space that I showed you before. So it can give you a hematoma there. And we've talked about late presenting diaphragmatic hernias, and we've talked about gastrointestinal sepsis, particularly finding pneumatosis or gas in the liver, where it's very likely to be a Clostridium perfringens infection or some sort of Clostridium infection. So that's all I wanted to say, to talk about today. I think it's useful to go through x-rays like this and think about how to interpret them and also what they might mean, etc. So, okay, any questions?